We are constantly told that, viruses are basically the primary drivers of gynecological precancers.
Right.
Like the entire public health infrastructure is built around screening for these viral changes. But today we are looking at a precancerous pathway that completely bypasses the virus.
Totally.
It just hides in plain sight beneath perfectly normal looking tissue, and it moves with terrifying speed.
It is the absolute definition of a diagnostic blind spot.
Yeah.
I mean, the stakes for the patients caught in that blind spot are incredibly high.
Because it's just dismissed, right?
Exactly. The clinical manifestations are so easily dismissed as just, chronic, benign irritation.
Well, welcome to the deep dive. Our mission today is to unpack a highly specific but critical area of women's health for you. We are looking at vulvar intraepithelial neoplasia, or VIN. And specifically, we're exploring the crucial differences between its two major forms and what they call the dualistic model. So that's usual VIN and differentiated VIN.
Right.
And more importantly, we're dissecting how chronic inflammatory conditions, particularly one called lichen sclerosus, how that plays a massive role in cancer risk.
It's huge.
We have a pretty heavy stack of medical sources today. We're looking at the 2021 European guidelines, some comprehensive case reports from Frontiers in Oncology, and several advanced gynecological pathology reviews.
Okay, let's unpack this.
So to understand the sheer danger of that stealthy inflammatory pathway, we first kind of need to look at the baseline we've established in gynecologic oncology.
A standard model.
Right. The dualistic model outlines two fundamentally different biological mechanisms that lead to vulvar squamous cell carcinoma.
Okay.
The first pathway, usual VIN or uVIN, which, by the way, is often referred to in the updated terminology as high-grade squamous intraepithelial lesion. That's the one our medical systems are highly trained to intercept.
And that's because uVIN is entirely driven by high-risk human papillomavirus strains, so like HPV 16, 18, 33.
Yep. And we are talking about a demographic of generally younger women here, with the average age of presentation hovering right around the early 40s.
Right, and clinically, I mean, it's fairly obvious during a routine exam.
Yeah, the sources describe uVIN as presenting as these raised multifocal lesions, typically clustered around the vaginal enters. It's very visible.
It is. And the pathophysiology of uVIN is characterized by a very slow progression.
How slow are we talking?
Well, the viral oncoproteins, specifically E6 and E7, they integrate into the host cell machinery and just gradually disrupt the cell cycle regulations.
Right.
But this process of transforming from a high-grade lesion to invasive carcinoma, it takes an average of 6 to 7 years.
Wow. That is a long time.
It really is. And furthermore, the absolute risk of uVIN progressing to cancer is relatively low. It hovers somewhere between 3 and 10%.
So uVIN operates kind of like a loud, obvious trespasser.
Oh, I like that.
Yeah, like the virus breaks in, leaves a massive trail of visible evidence, and sets off clinical alarm bells over a span of several years. It basically gives clinicians this massive window to step in and deal with it.
Exactly. And that slow, highly visible progression is precisely why uVIN is so preventable.
Especially now with, widespread HPV vaccination and robust screening protocols.
Right. But our success in managing this viral pathway has inadvertently created a massive systemic vulnerability.
Because we're complacent.
Yes. Because uVIN is so prevalent and well understood, it has essentially shaped the clinical expectation of how gynecologic precancers should behave. We expect them to be viral, we expect a slow timeline, and we expect obvious morphological changes.
Which brings us to the danger of the other pathway in this dualistic model.
The stealth pathway.
Yeah, the assumptions we rely on for the viral pathway do not apply, even a little bit, to differentiated VIN or dVIN.
Not at all.
We are dealing with an entirely HPV-independent mechanism here, and it strikes a very different demographic. The data points predominantly to postmenopausal women, typically in that 60 to 68 age bracket.
Right. And the clinical presentation is just aggressively unassuming.
Yeah.
Instead of the raised, warty, multifocal lesions we see with a viral infection, dVIN frequently presents as a single, poorly outlined white or pink macule, or just a slight thickening of the skin, or maybe a minor ulceration.
It just looks like a rash.
Exactly. To a practitioner doing a standard visual exam, it does not look like a looming malignancy at all.
Yet the numbers attached to dVIN in these pathology reviews, they are staggering.
They're terrifying.
While uVIN carries that 3 to 10% cancer risk, dVIN carries an absolute risk of developing primary vulvar cancer of 33 to 86%.
It's a massive jump in risk.
And the timeline is compressed drastically. The median time to cancer progression is just 9 to 23 months.
Yeah, it's incredibly fast.
Even the more conservative estimates in our sources cap it at 2 to 4 years.
It accelerates toward invasion at a speed that morphology alone often just cannot catch. And this leads to a really confounding statistical paradox in the literature.
Which is?
Well, when we look at isolated precancer diagnoses, dVIN accounts for only about 5% of the cases we catch.
Okay.
Some studies put it marginally higher, maybe up to 10%. Yet, when pathologists analyze excised invasive vulvar squamous cell carcinomas, they find dVIN sitting right adjacent to the tumor in 36 to 79% of all cases.
Okay, wait. I have to push back on those numbers.
Go ahead.
If dVIN is genuinely that aggressive and pathologists are actively finding it bordering up to 79% of the actual invasive cancers, I mean, the math on the precancer diagnosis rate makes zero sense.
Right, it doesn't add up.
How can it only account for 5% of the precancers we screen? Are clinicians just completely missing it during the preventative window?
What's fascinating here is the low prevalence of dVIN in the precancer stage is almost certainly an illusion.
An illusion.
Yeah, it is a byproduct of severe chronic underdiagnosis.
Right.
We are catching the uVIN cases because they sit there for 7 years looking abnormal.
Right.
But with dVIN, the precancerous window is incredibly narrow. Because the physical symptoms mimic simple irritation and the progression to invasive carcinoma happens in mere months, the opportunity to biopsy the lesion while it is still a precancer simply evaporates.
Because it's already cancer by the time they cut it out.
Exactly. By the time the patient undergoes an excision, the dVIN has already breached the basement membrane and become a carcinoma.
Wow. So to understand how this stealthy, non-viral pathway generates such an aggressive cellular mutation, we have to look at the primary underlying catalyst, which is chronic inflammation.
Yes.
The literature clearly links dVIN to chronic inflammatory dermatosis, primarily lichen sclerosus.
And lichen sclerosus creates a highly volatile microenvironment. It's a condition primarily affecting the anogenital region, characterized by intense pruritus, severe itching, and hypopigmented parchment-like plaques.
It sounds awful.
It is. Patients suffer from a really aggressive, localized autoimmune response.
The epidemiological data suggests that the risk of lichen sclerosus eventually progressing to vulvar squamous cell carcinoma is roughly 5%.
Right.
But the cellular mechanism is what's truly compelling to me. We aren't looking at a virus hijacking a host cell's DNA to replicate itself. We are looking at the consequences of chronic oxidative stress.
Yes, the constant localized inflammation recruits immune cells that release reactive oxygen species.
Which are basically chemical wrecking balls.
That's a great way to put it. Over a period of years, these chemical wrecking balls continuously bombard the epithelial cells, directly causing double-strand DNA breaks.
And coupled with that DNA damage is the constant demand for tissue repair, right?
Exactly, because the tissue is continually inflamed and often physically excoriated due to the intense itching, the basal stem cells are forced into a state of hyperproliferation just to replace the damaged skin.
And that's where the mutation happens.
Right. When you force cells to replicate rapidly in an environment saturated with DNA-damaging reactive oxygen species, you inevitably trigger severe genetic mutations.
One retrospective pathology study in our stack illustrates this perfectly. When expert gynecologic pathologists went back and reviewed archived tissue samples originally diagnosed as plain lichen sclerosus, they ended up reclassifying 42% of those cases as dVIN.
Almost half.
Yeah, almost half the time. What the original pathologists thought was just heavy inflammation already harbored aggressive precancerous mutations.
Wow.
I like to think about it like your own house. If you let a fire smolder inside the walls, the fire itself isn't what brings the house down. It's the years of relentless ambient heat structurally weakening the load-bearing beams. The inflammation of lichen sclerosus is that smoldering fire. The resulting deep genetic structural damage, that is dVIN.
Taking that analogy further, the clinical mandate becomes really obvious. A smoldering fire requires active suppression.
You have to put it out.
Right. The gold standard for managing lichen sclerosus isn't just about alleviating the itching. It is about halting that oxidative cascade.
So what does that require?
It requires highly compliant long-term use of ultra-potent topical corticosteroids.
Oh, wow.
The objective is to aggressively suppress the localized immune response. If you shut down the inflammation, you stop the generation of reactive oxygen species, and you prevent the genetic instability that drives the transition from normal tissue to dVIN.
Okay, so if the progression from lichen sclerosus to dVIN is an established pathway, the failure to diagnose it before it becomes invasive cancer suggests a massive breakdown in standard pathology.
It does.
And the sources detail exactly how dVIN disguises itself, both physically and under standard microscopy.
Right, so the clinical mimicry is the first barrier. To the naked eye, the lesions often present identically to a benign eczema or lichen simplex chronicus, which is really just the epidermal thickening that occurs from chronic scratching.
So a clinician looking at a postmenopausal patient with a history of vulvar itching is highly likely to just dismiss the lesion as a flare-up of their existing dermatosis.
Precisely. But the microscopic disguise, that is a fascinating failure of standard morphological assessment.
How so?
Well, with the viral pathway, uVIN, the viral oncoproteins force the cells to replicate chaotically without ever maturing.
Right.
Under a microscope, pathologists see full-thickness epithelial immaturity. The architecture of the tissue is completely disordered from the deep basal layer all the way to the mucosal surface. The dysplasia is unmistakable.
But dVIN doesn't do that.
No, dVIN bypasses this entirely through a phenomenon called surface maturation.
Right. The mutated clones are confined almost exclusively to the deep basal and parabasal layers of the epithelium.
Exactly.
And as those cells migrate upward toward the surface, they remarkably retain their ability to differentiate and produce keratin. So by the time they reach the top layer, they look like perfectly normal, mature squamous cells.
And that's the trap. If a pathologist is evaluating a biopsy using standard H&E morphology, their training, which is largely shaped by the uVIN paradigm, dictates that they look for full-thickness atypia.
They want to see the whole layer messed up.
Right. When they see a normal, well-keratinized surface layer, the instinct is to sign the biopsy out as mere reactive hyperplasia or just chronic inflammation, completely missing the highly aggressive atypical cells lurking in the basement membrane.
The Frontiers in Oncology case reports show the devastating real-world consequences of this surface maturation disguise.
They really highlight the tragedy of it.
Case study 1 details a woman in her 60s presenting with an unrelenting vulvar itch spanning a decade. She was continually diagnosed with vulvar eczema and prescribed various topical therapies that provided minimal relief.
10 years of that.
10 years. And when a biopsy was finally taken, the standard morphological review categorized it merely as squamous epithelial hyperplasia with chronic inflammation.
Because the pathologist observed the matured surface keratinocytes and the inflammatory infiltrate. They just interpreted the subtle basal atypia as a reactive change to the chronic scratching, rather than a neoplastic process.
It wasn't until a highly metabolic 2-centimeter mass erupted in her groin that the clinical picture shifted.
Yeah, that mass was a lymph node metastasis.
The cancer had already spread regionally. Only upon excising the primary lesion and conducting a retrospective review did the pathology team realize the original biopsy captured dVIN that was actively progressing into invasive carcinoma.
It is a profound systemic failure. And we see a similar trajectory in the second case study.
Right, the woman in her 50s.
Yeah, presenting with a bleeding, ulcerated lesion that was managed conservatively for months. Once the lesion was finally excised, the pathology revealed a fully invasive, well-differentiated squamous cell carcinoma surrounded by adjacent tissue harboring entirely undetected dVIN.
The precancer was hiding directly adjacent to the tumor it spawned. Here's where it gets really interesting. If the top layer of the epithelium maintains its mature structure and the atypia in the basal layer is subtle enough to be confused with just inflammatory reactivity,
Right.
standard morphological assessment is essentially a coin toss. Pathologists need a way to look past the physical architecture of the cells to identify the underlying genetic chaos.
And they have one now. Relying solely on standard H&E staining in these high-risk demographic presentations is just no longer viable.
So what's the alternative?
The diagnostic framework has shifted toward unlocking the molecular fingerprint of the tissue using immunohistochemistry.
Right.
By applying specific protein markers, we can visualize the presence or absence of key genetic mutations, completely bypassing the morphological disguise.
So the molecular profiling heavily relies on two primary markers to differentiate the pathways. We're talking about P16 and P53.
Yes.
In cases of viral uVIN, the tissue will consistently demonstrate block-positive staining for the P16 protein, which is a direct molecular surrogate for high-risk HPV integration.
Exactly. Furthermore, the P53 tumor suppressor gene will show a wild-type or normal staining pattern.
But dVIN presents the exact inverse profile.
It does. Because there is no viral integration, the tissue is completely negative for P16. The critical diagnostic key here is the p53 mutation pattern.
And P53 is arguably the most vital tumor suppressor gene, right?
Oh, absolutely. It's responsible for initiating DNA repair or triggering apoptosis in severely damaged cells. It's the guardian of the genome.
So the chronic oxidative damage from conditions like lichen sclerosus inevitably targets this P53 gene.
Yes, and the immunohistochemistry reveals this mutation in two extreme, highly visible patterns.
Okay, tell me about those.
The first is a diffuse, intense overexpression. The gene sustains a missense mutation, producing a faulty, stabilized version of the p53 protein that cannot execute its function but refuses to grade.
So it just piles up.
Exactly. It accumulates massively within the nuclei, lighting up brilliantly under the stain.
Wow. And the alternate presentation is the null pattern.
Right. The genetic damage causes a nonsense mutation or complete gene dilution, resulting in absolutely zero p53 protein synthesis.
So it's just blank.
Entirely blank. When a pathologist applies the stain and sees a complete absence of p53 where there should normally be patchy wild-type expression, it confirms the genomic guardian has been entirely knocked out.
And once P53 is compromised, the basal cells are just on an uninhibited track toward malignant transformation.
Precisely.
The diagnostic profile is further solidified by supporting markers like CK17, which highlights altered keratinocyte differentiation, and SOX2, which is a transcription factor associated with cellular plasticity and stemness that shows heavy amplification in dVIN.
And we can't forget Ki67.
Right.
The proliferation marker Ki67 acts as a molecular map of the chaotic growth.
So in a viral uVIN lesion, the Ki67 staining is diffuse, indicating active cellular replication occurring throughout the entire thickness of the epithelium.
Yes, but in dVIN, the Ki67 proliferation index is intensely confined strictly to the lower one-third of the epithelium.
It visually maps out exactly what we discussed earlier.
Yes, the hyperproliferation is restricted to the basement layers, actively driving the mutated clones, while the upper layers remain seemingly dormant and mature.
So using these markers is like spraying a chemical at a crime scene to reveal invisible blood. The tissue might look innocent to the naked eye, but the P53 stain makes the precancerous mutation light up like a neon sign.
That is a brilliant way to phrase it. Applying this immunohistochemical panel completely strips away the physical disguise. The surface might look like mature, unproblematic skin, but the P53 and Ki67 stains definitively expose the aggressively mutating basal layer.
That's incredible.
If we connect this to the bigger picture, the reliance on molecular markers rather than purely physical morphology is why the recent European guidelines and international consensus statements have drastically updated their protocols.
They're changing the rules.
Yes, they issue a very firm mandate. Any persistent, symptomatic, or visually distinct vulvar lesion in older women, particularly those of a documented background of lichen sclerosus, must undergo immediate biopsy.
No more waiting.
No waiting. And that tissue must be subjected to P53 and P16 immunohistochemical profiling.
So what does this all mean? The landscape of vulvar precancers is defined by two fundamentally different mechanisms that demand entirely different clinical approaches.
Absolutely.
The viral uVIN pathway is well understood, slowly progressing, and highly responsive to our current screening and vaccination models. However, the differentiated VIN pathway operates in the shadows.
It does.
It is driven by the sheer, relentless oxidative stress of chronic inflammation. It exploits our reliance on standard morphology by retaining a mask of normal surface tissue, all while rapidly mutating in the basal layers and accelerating toward invasive carcinoma in a matter of months.
There's a race against time.
For the clinician and the patient, the critical defense is vigilance, recognizing that chronic inflammatory dermatoses like lichen sclerosus require aggressive, continuous topical management to suppress the molecular damage.
Right, put out the fire.
Put out the fire, and utilize immunohistochemistry to definitively catch the mutations before the precancerous window closes.
You know, we dedicate massive global resources to fighting cancer by developing antiviral vaccines and targeting established tumors.
Right, billions of dollars.
But the pathology of dVIN presents a profound paradigm shift.
How so?
When we see how localized chronic inflammation can systematically dismantle cellular DNA and knock out tumor suppressor genes simply through persistent oxidative stress, it forces us to look upstream.
To the root cause.
Exactly. The next critical frontier in oncology may not merely be about neutralizing pathogens or excising tumors, but mastering the biochemical interventions required to definitively cool down the body's own localized inflammatory cascades before they irreparably shatter the genome.
Before the fire burns down the house.
Exactly.